Morning, everyone. You hear me okay? Happy Monday. Thanks for coming. This is our annual 2025 Kevin Graham Prevention Lecture. So you guys all know Kevin quite well. He's one of the leaders of MHI, and he actually started our prevention program in 1999, which is a time when there weren't a lot of prevention programs in private practice groups. So we're very happy to have his visionary leadership. And so he started this lecture in his honor. And we've had multiple good speakers over the years. I didn't mention Sek Kathair and we had him as well. So yeah, a lot of really good speakers in the past, and today we have an excellent speaker as well. I'm going to stop and thank our sponsors also. It's Johnson & Johnson and Merck today. Thanks for supporting this lecture. And so yeah, our 2025 speaker is Dr. Matt Budoff. He is currently a professor of medicine at the David Geffen School of Medicine at UCLA and the endowed chair of preventive cardiology at Harbor UCLA Medical Center. And he said I can just summarize his intro because it could go on for quite a while. He is simply one of the world's leaders in prevention and cardiac CT. And so today he's going to tell us about cardiac CT in 2025. Dr. Budoff.
Thank you very much, and it's certainly a pleasure to be here. And thank you for the invitation and the hosting. I did want to take you through a little bit of. I know that you're a heavy user group for CT already, so I didn't want to go through the basics, but I did want to show you a few highlights of where coronary calcium may be helpful. And then I heard you're going to hit all-time highs for coronary calcium use, and then focus a little more on how we can use CT, I think, and how it's going to be used moving forward now that we have AI and ability to track atherosclerosis a little more robustly. There's not great randomized trials of coronary calcium to show that if you get a calcium score, you live longer, although there is emerging data from Europe that I think will be helpful in this regard. But I do think that this study does at least lay down the concept here. This was a trial that was done a long time ago, actually in the late 90s. They used atorvastatin 20, which was kind of considered a high dose back in the day. And they also added in antioxidants. They thought there was going to be an antioxidant benefit, which obviously kind of fizzled out after the 90s. But they did this trial where they randomized patients who had a high calcium score to either atorvastatin 20 or placebo and followed just 1,005 patients, a small study. But as you'd expect, atorvastatin worked and it lowered events by 30%. But more importantly, the number needed to treat was actually very low. They had a 3% absolute benefit, which means from primary prevention, you treat 30 patients and one of them does not have a cardiovascular event over the next 4 years. And when you had calcium scores that were higher, they looked at 400 as a pre-specified subgroup. The absolute benefit was 6.3%, which means if you take a patient who has a high calcium score and you put them on just atorva 20, you only have to treat 16 patients to prevent an MI stroke or cardiovascular death. And for an asymptomatic population, that's just a remarkably low number needed to treat. It might be the lowest number needed to treat of any primary prevention study done. But I think the bigger problem we have in prevention is the aspirin story, and it's changed a lot. And if you're, I'm not a big fan of the U.S. preventive task forces, but if you were, this is where they flip-flop back and forth. They used to recommend aspirin for all, then aspirin for none, then aspirin for some, and that's where we are now for primary prevention. Some people should be on aspirin, but you have to be high cardiovascular risk and low risk of bleeding and all of these caveats because the data is kind of mixed. But if you sort out who has atherosclerosis, who's likely to have an event in the near future, I think aspirin makes more sense. So this is data from MACE. So this is actual event rates. So this is not theoretical or models. This is just what happened. And if you look at low risk patients and you said the red line is number needed to harm, the numbers, if the bar goes above the red line, then that means that the number needed to treat is worse than the number needed to harm, and you're upside down on risk benefit. You're going to harm more people than you benefit. So if you took low risk people and treated all in blue, 2 to 1, you'd have more bleeds than prevention of MI, stroke, or death. But when you get to calcium scores of 100, which is in light green, or 300, which is in dark green, or 400, which is in dark green, you can see the number needed to treat is much lower than the number needed to harm. And actually at a score of 400, you are 8 to 1 in favor for a low risk patient who has a lot of calcium, not that common. But if they have a high calcium score and you put them on just low dose aspirin, you're going to prevent 8 MIs, strokes, and deaths for every 1 bleed you're going to cause, which is sounds pretty good to me. So I do that. And it worked in every cohort. If you look at intermediate risk, the same thing. Light green is a calcium score above 100, 2-to-1 favor for MI versus bleeding. And I wouldn't even say those two things are exactly equal. And then on the far right, if you're high risk, you can see exactly what happened in the trials. Look at the blue line. The blue line in high risk is overall the number needed to treat and the number needed to harm are exactly the same. There's no benefit to aspirin. But if you sort out and get rid of those zeros in orange, where the number needed to treat is high and the number needed to harm is not that high, you actually have a much better favorable response. So the newest AHA guidance is calcium scores above 100. You should consider aspirin for asymptomatic patients, not at high risk. And I think that's now in 8 guidelines around the world. So I do use low-dose aspirin for patients with high calcium scores if they don't have a high bleeding risk. This is a condensation of the 2018 ACC/AHA prevention guidelines. And you can just see calcium score of 0, below the threshold for statin benefit, consider avoiding or postponing drug therapy. For calcium score of 1 to 99 and less than the 75th percentile, it's really dealer's choice. Talk to the patient. You decide if they have a little athero, should you treat them, or you can wait. Either one is probably reasonable because they are low risk for the next 5 years. It's not a lifetime guarantee, but I think it's a pretty good 5-year guarantee. And if they have a high calcium score or they're above the 75th percentile, you're above the threshold for benefit for statin, and that's where you would use statin. And the range is now 5 to 20%, which is pretty broad. So we actually have a nice range of primary prevention patients where calcium scoring is indicated, and a lot of payors are now starting to pay for coronary calcium. We're seeing a lot of them starting to adopt these guideline recommendations and pay for coronary calcium in this low to intermediate risk. But many of you might just be, especially in the prevention world, you're like, well, come on, I mean, I can just primordial prevention. I'm just going to put a patient on a statin regardless, because why not prevent the first event? And I would say that if you don't have athero, that's probably not going to be of benefit to them. And that's not my opinion, but based on very large observational studies. So this was just one of them. This is the Walter Reed study. So this is in the military, very closed healthcare system, great long-term observational data. And they knew exactly what happened to everybody because they can only get their health care in the military. And this is the patients who had calcium score of 0. This represents 9,350 patients, so a large cohort of patients, followed for 12 years. Again, 100% follow-up in these patients. And you can see there's actually 2 lines of events there. The event rates were low, but there's 2 lines. There's a red line and a blue line. Red line are 3,700 patients who are on a statin, and the blue line is 5,600 patients who are not taking a statin. And if you can see a difference between those two, you've got better eyesight than I do. They literally had to make the line alternating blue and red hashtags to be able to show it on this curve. The hazard ratio was 1.00, as neutral as you could possibly get. I'm not sure why the p-value was only 0.99 and not 1.00, but the statisticians always mess us up a little bit. But absolutely no benefit, not even one patient benefited over the course of being on a statin for 12 years. So calcium score of 0, I think you have a very nice, at least 5-year warranty where your event rates are going to be very low, and there's no evidence that statins will do anything at all, at least to lower your event risk. Well, maybe the trial just was neutral. Maybe it didn't work. But look at where we do recommend statins with calcium score above 100. And this is very nice curve separation. Look at the red line. That's statin use. Look at the blue line. That's no statin use, exactly what you'd expect. At 5 years, there's about a 35% event reduction, exactly concordant with every statin trial we've ever done. And as you follow them out to 12 years, you actually get a 68% event reduction. Number needed to treat now, 12. So you go from a number needed to treat of infinity to a number needed to treat of 12 if you use calcium scoring to decide who needs statins in primary prevention. So I think this is at least great observational data. We'll never be able to do a trial in calcium score of 0, because to do a non-inferiority study, it has to be 2x times the power. And if you need infinity, you'd have to do a trial in 2 times infinity patients to show a potential difference or a similarity. So we're not going to do trials in calcium scores of 0, but I think a lot of long-term observational data shows the futility of putting them on statins to prevent events, at least. If you want to do other things, that's fine. So what about calcium scoring and elevating risk? Well, that's also been shown. This is the CONFIRM registry. This is another 23,500 person follow-up study done in multiple centers. And you can see blue is calcium score of 0, low risk. And red is a calcium score that has 1 to 99, a little more risk. And black is 100, where they start to get some significant risk over 7 years of follow-up. But there's a purple line up at the top and a yellow line perfectly superimposed. And purple is asymptomatic people with a calcium score above 300. And yellow are post-MI survivors that were also in this CONFIRM registry. You can see that a calcium score above 300 is exactly the same risk as a person who's already suffered an MI. And I always thought, we should get rid of this primary and secondary prevention because risk is a continuum. And the only difference about primary prevention and secondary prevention in some of these patients is some of them had a very bad day and some have not yet had that bad day, but they have the same risk of having another event. So this is also starting to be adopted in guidelines where a calcium score above 300 becomes a secondary prevention target, and you can start accelerating therapies such as PCSK9s, icosapent ethyl, colchicine, drugs that were only studied in secondary prevention to maybe start that therapy before they have that bad day. So the AHA came out with a presidential advisory. This is really to introduce their CKM, or cardiovascular, kidney, and metabolic health program. And you can see calcium scoring is the only, so stage 0 is no disease, and stage 4 is overt heart disease. And the only thing in stage 3 is coronary calcium. So stage 3 is subclinical CVD. And for ASCVD, it's only defined as a calcium score. There's no other testing that they advocate for. Calcium score above 0 favors statin use in intermediate risk, and a calcium score above 100 favors aspirin, and again, more advanced therapies depending on their cardiovascular, kidney, metabolic profile. I like this. This is Nathan Wong from Irvine helped with this guideline just to show you maybe where we're headed. We always talk about new guidelines and lower LDLs, ever lower LDLs. And you can see they're now targeting for a high calcium score in India, optional target less than 30 on the far right, less than 30 milligrams per deciliter for this calcium score above 300 for what we would call a secondary risk equivalent. So we are getting there with lower and lower LDLs. I think this is a little too aggressive. And they start with individuals 30 and above, which I think is the wrong age for calcium scoring, because we don't usually see calcified plaque until at least age 40. So I would warn you not to rely on a calcium score in patients who are in that 30 to 40, maybe even 30 to 45-year-old range. David Marin and I and a few other people came up with these guidelines. It's not laid out very cleanly, but as the calcium score goes up, therapy goes up and LDL targets go down. So this is a nice little guideline, coronary calcium staging guide, which was thought to be hopefully helpful for clinicians to when to institute aspirin, when to be more aggressive, when to go for lower LDL targets. So I think in the calcium world, we're pretty. We're in a pretty good place here, and I'm sure all of you have seen this if you've ever ordered a calcium score, especially number 2, where if they're reluctant or intolerant to a statin, and then you show them that they have a lot of plaque in their coronaries, all of a sudden they're willing to give it one more try. We were talking about the statin intolerant groups last night, and this is one way that I've convinced a few of them to at least give it a shot, especially those people who just read about it and didn't think it was a very good therapy. When it becomes personal, they often will give it a try. And family history, I think, is dramatic benefit, because you have no idea, at least nobody that I know of has any idea what genes cause heart disease. So dad or mom or other people in your family might have had heart disease, and you might be at increased risk. You have no idea if you have the genes or not, because we don't know what the genes are. So if we can't genotype you, we can phenotype you. And that's where calcium scoring, I think, plays a huge role, where you can decide, and I had two younger women, and I thought they were both too young to get a calcium score, but they were there for some news story and they wanted to go undergo the test. And they had an older cameraman. So I'm like, let's do the cameraman because he'll have some plaque. So this older, heavy cameraman gets on the table, score of 0, nothing there. And these two women are like, well, Dad had heart disease. One of them had a very high score, and the other one had totally normal calcium score, and they were pretty close in age. So you just don't know about that transmission of family history until you take a look. But I think it can help us. It helps us. It helps me with aspirin. It helps me with motivation. I think the most important thing about a calcium score is that it does get the patients to be better patients. Because I learned a long time ago, you can't make an asymptomatic person feel better. But with statins, or at least a perception of statins or other therapies, you can certainly make them feel worse. And I think that we need therapies that are helpful in this algorithm of care. I was surprised to see this in the 2023 appropriate use criteria for asymptomatic patients. All that red is don't do a nuke, don't do a stress echo, treadmill maybe, but never really hit appropriate. But calcium score actually did better than any test, including no test, in asymptomatic people. The recommendations are it's appropriate and highly appropriate to do something. And it's never inappropriate to do a calcium score in an asymptomatic person, according to these multi-societal guidelines. So we are coming around to this concept of near universal testing for coronary calcium. What about calcium progression? And I'm not a big advocate of repeating the score, but a lot of patients who get a calcium score want another one at some time point to see how they're doing. And I have to tell you, if their score is going up by a lot, they are at high risk. And I've done a few trials, and there's a few other smaller studies. This is one from my cohort, 4,600 patients. And if you look at a calcium score of 100 in patients who are not progressing, so defined as less than 15% per year change, so they're non-progressors, their risk is actually fairly low, even though they have a calcium score of 100, but there's still some risk stratification there because they have plaque and more than scores of 0. But if they are progressing, if their score is going up on average by more than 15% per year, they're actually at quite high risk. And this is just death. So a huge, huge difference if their calcium score is going up or not. We did another study in MESA and saw the exact same thing. In red are patients who are rapidly progressing per year. And they had very high event rates. And the patients who had a little bit of progression, including those on statins, who had a little bit of progression because statins may be stabilizing the plaque and increasing calcium, were in that orange line. And that orange line is the exact same as the purple line, which is no change at all in their calcium score. So for progressors, progression matters. And this is controlling for everything. So if they're going up by more than 15, some people use 20% per year, something else is going on. That's not a statin effect. That is atherosclerosis being laid down. You have not achieved quiescence, and I do accelerate therapy. But I think all of that can go away with CT angiography. Now, the problem with CT angiography is still it's more time intensive to read, for sure. For any of the readers in the room, you know what I'm talking about. These are not so easy. I can read calcium scores as quickly as I can read an EKG pretty much. I can't do that with my CT angios. So this is a problem. But we can get doses quite low, and we can get really beautiful pictures. And it is better than a calcium score. This is work we did now many years ago. In blue is our risk factors, and that's your area under the curve for prediction of events. And in yellow are risk factors plus calcium score. Calcium score is always better than risk factors at predicting events. But very nicely in orange, risk factors plus calcium plus CT angio, the prediction of future events was quite high. So CT angio definitely affords more information. We can see non-calcified plaque, or what we call soft plaque, and we can see a lot of different plaque components. We can see lipid-rich and fibrofatty and low attenuation or vulnerable plaque. We can see remodeling, and we can, of course, see stenosis. So that becomes attractive for the interventionalists as well. So CTA is great, and it's good in the young. So in a young person, we do low-dose CT angio instead of calcium scoring because we can't see calcified plaque. We did a study of patients with type 2 diabetes who developed risk before the age of 4 or developed diabetes before the age of 40, and we did CT angio, and a third of them had non-calcified plaques only, and no calcium, but they had measurable plaque. And this patient with that black arrow shows a pretty large plaque burden. So I think for the young, if you are worried about them, they have diabetes, they have a terrible family history, they have heterozygous or homozygous FH, you're going to have to do a CT angio if you want to see what's going on in their coronary bed. If they happen to have calcium, that's bad, and we don't probably need to do much more. But if they don't have calcium, they might still have non-calcified plaque. The guidelines for asymptomatic patients are not there yet. I didn't show you, but in those appropriateness criteria, it was for CTA, it was all red still. There was no appropriate use of CT angiography for asymptomatic patients. Now, that'll probably change with some outcome studies. We have a number of trials that are ongoing right now, but until those trials come out, it's going to be an uphill battle, and it's mostly a cash pay business, I think, for the foreseeable future. But this European guideline in 2019, if they say patients with diabetes or a family history of heart disease or risk assessment says that they're high risk, maybe such as a calcium score that's abnormal, functional imaging or coronary CTA may be considered for cardiovascular risk assessment, class 2B recommendation. So we do have at least a weak recommendation for asymptomatic people to get a CTA. At least in Europe, and we usually follow the Europeans. We used to lead the way in the US with guidelines, and now we follow the Europeans by about 2 years in everything that they say. So if you want to see what our US guidelines will say, just read the European guidelines, and it's usually a pretty good foretelling. Chest pain, heart failure, prevention. We've been following the Europeans for the past about 10 years. They've become a little more mobile, faster in their getting out guidelines. So what about looking at prevention therapies and interventions and see if we can lower the cardiovascular risk? Well, we're turning into, and this happened in Europe in 2 years earlier, but these are our 2021 guidelines, first authored by Martha Gulati, one of your former lecturers here, that CT angio is a class 1A recommendation, and it's actually the only test that received a 1A recommendation. There was only two 1A recommendations for diagnostic testing in a 55-page document for guidelines. And the only two 1As were patients who have stable chest pain to do CT angiography, and patients who have acute chest pain to do CT angiography. That was it. There was no functional testing, no new PET, SPECT, no stress echo, treadmill got a 1A recommendation, only CT. So we are becoming a CT first algorithm like Europe, and this is really a very strong statement. CT angio is effective for diagnosing coronary disease. Of course, that's what we use it for primarily, but it's also useful for risk stratification and for guiding treatment decisions. And I think that that's really important, because the most important thing that can help us as clinicians is a test that can guide treatment decisions, right? We need help in what to do next, because we're in the age now. I mean, back in the day when I started doing cardiology, I'd tell people, you need to get calcium scoring. It's great. It tells you who needs more therapy. And they're like, look, I already have them on an aspirin, a statin, and an ACE inhibitor. What else am I going to do? And I'm like, oh, you're right. They don't need a calcium score because that's the only things that work. But now we have so many drugs that have been proven to be incremental to statins that that's impossible now. If you tell me somebody's on everything, then either that's all they do is take meds all day long, or you just don't know the literature, because it's almost impossible to get them on every drug that's been proven to be better. There's 9 different therapies now on top of that have been proven incremental to statin therapy for preventing MI, stroke, or cardiovascular death. 9 classes of drugs, not 9 drugs. So the nuclear, stress echo, stress MR, treadmill didn't do so well. It got a 1B recommendation. It got a hyphen for non-randomized data. So a little asterisk saying the data is not very strong. And all it says is it's useful for the diagnosis of myocardial ischemia, not for diagnosing coronary disease, which is what we might want to do, especially if we want to think about taking them to the lab. We know it's 50-50 in the cath lab. In the US, it's 55% of all caths done after a nuclear test are normal or mildly abnormal. They have less than 50% stenosis. That's been going on for at least a decade from the National Cardiovascular Data Registry, the NCDR. You can see they didn't recommend it for guiding treatment decisions. They didn't recommend it for risk stratification. And if you don't think this is a big deal and not a very strong recommendation, this was another multi-societal guideline that was signed off by 8 societies, but 9 societies were at the table at the time. And American Society of Nuclear Cardiology actually took their name off the document at the end, even though they were at the table and they helped write it, because they couldn't accept that it was playing second fiddle to CT and that it's not recommended for things like risk stratification or guiding treatment decisions. So we are going to move towards a CT first. And why? Because we can stratify risk better by far than functional testing. And that was shown in the ischemia trial, but it was shown in the COURAGE trial. It was shown in any study. When you compare anatomy to physiology, anatomy always wins, always. There's no exception. There's many trials now. Vinci, Pacific, all of them show that if you want to stratify risk and who's going to have an event, the person with more atherosclerosis wins. And this is not a new concept. Sydenham in the 1600s, so 400 years ago, literally said, a man is as old as his coronaries. Because when he was doing autopsies and looking at why people drop dead, he would see all these advanced plaques and all of this hardening of the arteries, atherosclerosis in the coronaries of these young people who dropped dead because they had the arteries of an old man. So here we have staging now for CT angiography. And there's a number of different staging algorithms, but this is just based on how much plaque is present or how much percent atheroma volume is present, something we can't really do when we read the studies. This is AI now. But CT angioplaque staging is now very possible. I know you guys use Clearly. That's one of the companies, but there'll be about 10 companies on the market within about 2 years. There's already 5 that have FDA approval. You'll see a lot of competition to give you plaque quantification, but very nice data. Look at that red line, 10-year follow-up, 0 events if they had clean coronaries by CT angio. No events occurred. In green, a little bit of plaque. They had more events. In dark blue, they had more events, and in light blue, a lot of plaques, what they called stage 3, a pretty high event rate. 50% of patients had an event over the next decade. It dramatically improved the risk calculator, and the net reclassification was very large, 0.21. So if AUC's areas into the curve, hard to move those. You have to be highly predictive. If you look at the cumulative data for high sensitivity CRP, and Paul Ricker will say this as well, it moves the net reclassification or the area under the curve by a significant amount, and it's statistically significant, but it moves it by 0.01. That's how much it moves it by when you do a meta-analysis. This moves it by 0.21, 21 times larger effect in reclassifying patients to tell us who's going to have an event over the next decade. There's other risk calculators. This is a nice study, 2,800 patients from UK. They called it Fish and Chips, a good United Kingdom name of a trial. And yeah, exactly the same data, right? No plaque. And I think this shows us a very important thing, though. Look at the green. The green are patients with a little bit of plaque by these AI calculators. And I have to say, at least my own bias is that they're too sensitive, at least when I look at a study as carefully as I can, and I don't see any plaque. And then I get these AI tools back. They say, oh, there's plaque there. And then I look again, and I still don't see anything. And they claim that they're better than us and that they have better eyes because it's AI and they're smarter than us. But if you look at the event rates that occurred in patients with mild amounts of plaque by AI, those two lines are almost perfectly superimposed. They said that it was a 1.2 risk, which was not statistically different, but I don't know, that green line and that gray line, zero, no plaque at all, and a little bit of plaque look like they're pretty darn close together. So I would say that minimal plaque is probably over-calling it, and they might be in the zero category. And they're certainly, by our eyeballs, in the zero category. So I treat that trivial plaque, I just say, look, the AI tools are too sensitive. Don't worry about it. I think your coronaries are completely normal, and I use my own eyes for that. But once plaque starts going up in whatever that ugly green color is, or the yellowish color, or orange or red, you can see a significant risk stratification, even in an asymptomatic population. And we can see so much more, right? I mean, with CT angiography, we can not only see, this non-calcified or calcified plaque, but they could stratify calcium based on how dense it is. And the more dense it is, the lower the risk, the older it is. So super dense, what they call 1K plaque, over 1,000 Hounsfield units, really dense on CT, really, really stable plaque. And then they have all the way down to very dark stuff with that red star at the very top, black as can be, and that's necrotic core, and that's vulnerable plaque or low attenuation plaque. And that's very highly concordant with what we see in the cath lab when we do OCT or IVUS to the necrotic core. We've done a lot of IVUS studies. These are just from the old 64 slice scanners. There's more IVUS data now, and there's AI versus IVUS. There's a ton of data that shows they're highly concordant. The plaque we see on CT highly correlates to the plaque we see in intravascular ultrasound. So we definitely know we're measuring the same thing, and we can use all those great lessons we learned from IVUS and now apply them to a much easier to do and non-invasive tool. So can we use it to follow patients over time? And I think that's where I think we're really making strides. We're seeing great advances here with following plaque over time. And it's important because if patients have plaque progression, these are 2 CT angios, and they looked at cardiac events after the second CT angio. And you can see most things once you put them in multivariate analysis, didn't really predict anything. I mean, age was 1.00 because you knew how much plaque they had. You took age out of the equation. Being a male is still bad. Previous acute coronary syndrome was still bad. But what was really, really bad was having plaque progression. And when you start seeing the CT angio looking worse, and these are before AI tools, when it looked significantly worse, they were really high risk for having another event. So can we do things about it? Well, this is one of my first forays into serial studies. The NIH actually came to me and said, we want you to do a serial CT angio trial in this testosterone trial because we don't know if testosterone is good or bad. And I'm like, I think it's a little early. We don't really have longitudinal serial data yet. And they go, so that's all right. So they funded it literally. I didn't even put in a grant. They just funded the study. This is what we found. Mike Lauer did this. He funded it. And blue is placebo and red is testosterone. And you can see every type of plaque got worse. And the investigators were so upset, the primary investigators, because they thought testosterone was going to reduce events and reduce plaque. And they were so upset, they made me do reproducibility studies. We published that the reproducibility in my lab was 0.99 between readers. They made us redo all the analyses because I didn't do the math. They did the statistics. I didn't have any of the data on the patients. I still don't. But testosterone was bad across the board. It worsened fibrous plaque, fibrofatty plaque, low attenuation plaque, total plaque, and non-calcified plaque significantly. But we have the opposite, right? So we can maybe worsen atherosclerosis, and I think testosterone repletion, especially at high levels, is dangerous. But we have things that can maybe help. This is statins. This is from Michael Liu's lab and Pam Douglas from Duke ran this REPRIEVE trial. And you can see regression of atherosclerosis in the pitavastatin group. You can see in purple a change from baseline minus 1.7. And low attenuation plaque got better. So there wasn't a lot of plaque in this group, but they did see a significant subgroup of patients who had regression of atherosclerosis, at least the soft plaque, with statin therapy, as you'd expect. I did this study called EVAPORATE. This looked at icosapent ethyl, or what we call Vascepa, 4 grams a day versus placebo in patients with atherosclerosis. And when you add it to a statin, you're in the blue group at the bottom, and we saw regression of plaque when we added icosapent ethyl to hypertriglyceridemic patients on a statin. So if they have statin plus persistent hypertriglyceridemia, we showed regression, and this was a parallel study to the REDUCE-IT trial, which showed event reduction. So we have nice parallels: statins, plaque regression, less events; icosapent ethyl, less events. We have data from colchicine. This is a study I just presented. We called it the Ekstrom trial because it was funded by the Ekstrom Foundation, which I don't know what that is exactly, but they gave us money, so great foundation. I'm a big fan. And we saw a significant slowing of percent atheroma volume or total plaque. The PAV went down was 1% less. 1% reduction in progression of percent atheroma volume is equivalent to about a 25% event reduction from the IVUS literature, which is very concordant with some of the larger colchicine trials. So I do think that colchicine may be a good thing, and you can see across the board, non-calcified plaque, fibrofatty plaque, and fibrous plaque all went the correct direction under the influence of colchicine versus placebo. A small trial done, Dan Berman's group did this trial looking at PCSK9. He used evolocumab and saw non-calcified plaque went down quite a bit, and low density or necrotic core, low attenuation plaque went down a lot. So I think we have good concept, and it predicted reduction in coronary microcalcification activity on PET. The keto diet, I'm not going to go into great detail. It was just an observational study over 1 year, but we did serial CT in patients who had LDLs of about 250. These are lean mass hyperresponders. They're lean, healthy people, as healthy looking people as you'd ever see, fit, exercise a ton, but they're on the keto diet and they only eat meat, basically very similar to the carnivore diet. You can see about half of them on the waterfall plot had plaque progression. A few of them had a lot, but about half of them had no progression. On the right is my data from the quantitative measure from manual measures. You can see very few regressors and some progressors, but a lot of people with not much plaque, at least over 1 year. So not everybody behaves the same, and I do recommend for anybody on the keto diet to get a CT angio to make sure they're not in that far right group with a lot of plaque and then a lot of plaque progression. But, I mean, the argument could be, come on, we don't need CT angio. I mean, just put them on a statin and call it a day. And I think we all recognize this is pretty complex. I don't know how many people are using it. I was going to recommend Dr. Khan for your next lecture, but I'm not sure this is as practical. Maybe with EMR we can do all of this, but this is a lot to put into one algorithm to try to risk predict. And it's still a population-based assessment. It doesn't tell you what's happening in the individual. So I'm not sure this is correct. And even if you just say, I don't really even care, I'm just going to put them on a statin, we all know that statins lower events, there's no doubt, but they lower events by 30%, 40%, which means 60% are not. And they say, well, that's fine. They didn't get the LDL low enough. So I'm going to go down to an LDL of 30. And I don't think anybody advocates in the world lower than 30, but we did that. We did that in a trial called Fourier. And we got the LDL down to 30. And at 12 weeks, it was 26 milligrams per deciliter in that red line. And there was an event reduction compared to statin monotherapy in the blue line. It was a 20% additional benefit. But literally exactly 80% of patients who were destined to have an MI still had their MI with an LDL of 30. So if you think 30 is safe, you're wrong 80% of the time, literally. So you have no idea, based on LDL alone, who's going to have an event and who won't. And you can get the LDL down probably to 0, and you're not going to get 0 events. You're going to have events. So we need to track atherosclerosis, and we need to figure out who's progressing. This was a patient who came in, they had some plaque. I put them on a statin, high-intensity statin. They had more plaque. At follow-up, I don't advocate for routine follow-up with CT angio, but this person wanted to kind of track their own athero. They got a CT angio. A year later, they had more plaque, measurably more. We added a PCSK9, and they started regressing. And they started regressing, and that was great. And we said, okay, we got you there. But we have patients who we put them on a PCSK9 and their LDL is perfect and they're still progressing. And I think now those are the patients that we might want to think of those other 8 classes of drugs that might benefit patients, whether it's icosapent ethyl or colchicine or the anti-diabetic agents or bempedoic acid or whatever else we think, ezetimibe, whatever we think in our toolbox might be the right next step. We might want to think about doing something more if they're progressing. And I think we can achieve this. This is just taking a statin, and this guy did fine. He stabilized his plaque. Blue is good. Blue is the calcified plaque. Yellow is the bad stuff. And he went from only almost exclusively non-calcified plaque to largely calcified plaque. And his plaque didn't go down much. He stabilized it, but his non-calcified plaque went down by 60%. And that's, I think, what we want to see. So I said, statin's enough for you. You're going the right direction. Your plaque is regressing and you don't need more than a statin. So this helps me determine when enough is enough. And I think that that's going to be very helpful because there's a huge spectrum out there of responses. And we can see this plaque went from 50-50 calcified and non-calcified to almost all calcified plaque, which is probably a much more stable marker. So we have staging with treatment now, just like we have with calcium scoring. This is put forth by the American College of Cardiology Prevention Working Group. Although interesting, it wasn't published in any of the JACC journals. It was published in American Journal of Medicine, so I'm not really sure how that happened. But statin plus ezetimibe for mild stage 1 plaque. For moderate atherosclerosis, you can add in things like aspirin and consider rivaroxaban and GLP-1 if they have diabetes. And if they have more severe plaque, then inclisiran, bempedoic acid, colchicine, icosapent ethyl, and PCSK9s all go on the table. And then they have some advocate for when it might be reasonable to take another look to see if you're doing the right things. But a lot of drugs on that list of incremental therapy, and you have to kind of know when to put them on. So I'll leave you with this thought that we need better tools in prevention because patients aren't complaining of pain and relieving the pain isn't our goal. They're asymptomatic, so we can't make them feel better. So we need to identify which patients are not responding. And I think if you just rely on LDL, you're going to be very disappointed in some of your patients who continue to either progress or have cardiovascular events. I don't think we're ever going to go lower than 26 or 30 milligrams per deciliter in a large clinical trial. And they still only reduced events by 20%. We have ample treatments available, but we need to know who and when to use them. Again, a lot of different drug classes that have shown incremental benefit, but when to put them on board is going to help us. We can have these wonderful now plaque progression tools. They're validated, they're rapid, they're largely reimbursed. As of October 1st, just a couple days from now, 3 more large US payers are going to start paying for plaque assessment. So I think that's going to be a huge move in the right direction. These are accurate and patient-specific insights I think can really help us and help the patient. They're going to respond better too when they know that their plaque is worsening. They're going to hopefully be better patients. So I'll leave you with our first preventive cardiologist, Dr. Machiavelli, back in the 1400s. At the beginning, a disease is easy to cure but difficult to diagnose. But as time passes, not having been recognized or treated at the outset, it becomes easy to diagnose, but difficult to cure. And I think anybody who's been in the cath lab will appreciate that concept. So thank you very much, and I'll be glad to answer any questions. And I was thinking about him as a speaker, but he's not available. His period is pretty busy right now. So.
Thank you, that was fantastic. Any questions?
I have 2 questions. You know, there was a paper in the New England Journal, I think it was observational about testosterone. And, you know, patients ask a fair bit about testosterone supplementation. That New England Journal article suggests that testosterone doesn't change your cardiovascular risk. But I wonder if the problem with that is if you took all the people who didn't have atherosclerosis and you put them into those groups, obviously it probably doesn't harm you if you don't have it.
Right.
So maybe one of the challenges for us, and if our patients are asking them for it, maybe we should do a CTA first and say, okay, you're fully clean, go ahead, or you're not clean, maybe you shouldn't.
Yeah, no, I agree. The Traverse trial, I wrote an editorial. I said should it be called Traverse or Travesty? Because it was really a terribly done trial. It was done by pharma. 62% of patients dropped out of the trial, so one of the worst follow-up studies ever. But I think the most important thing, yes, it was safe, but the average testosterone achieved was 350, which is the bottom of normal. They were targeting 350 to 700, and the on-treatment group barely hit 350, and actually for most of the trial, the average testosterone was below 350. So I think if you target a low dose or don't take it, as it was not being taken in 62% of patients, we don't see more events. But I wouldn't take that as the end all, and I think patients who get high, especially those men who want to get, we were talking about this earlier, above 1,000, really high levels of testosterone repletion above normal for total testosterone, I think you're going to see plaque progression. But I ask my men to at least get a calcium score and make sure that they're in a safe place. And I think following them over time will be very helpful. I had one patient just 2 days ago. I was in clinic a few days ago on last Thursday, and he had dramatic plaque progression. And he came into my office because his plaque went up, his calcium score tripled over 3 years. It went from 120 to 450, and his plaque on his CTA had moderate stenosis now in his LAD. He didn't have that 3 years ago. And he came in and he was fit, 61-year-old guy. His A1C was perfect. His Lp(a) was less than 15. His CRP was normal. His ApoB was low. Like, I'm thinking, like, I have nothing to offer this guy. It's just bad luck that he's progressing. And maybe we'll think about colchicine. His triglycerides were low. He looked great. And then I saw at the bottom of his labs his testosterone levels, and he was running well over 1,000 for those 3 years. And I think that was clearly driving his plaque up. And he's now going to back off a little bit. I don't think he's going to stop it because these guys like the juice. But I think they're going to beat it. But I think you should keep an eye on these people and don't go high with the even the Traverse trial didn't go high with the repletion.
Then I have one other question or observation. This is somewhat unique, but I have a transgender female to male. He actually has a pretty high family history of coronary disease. And he and I had a very frank conversation about, you know, his transition risk by taking a lot of testosterone. I hadn't thought of that, and now I'm glad that I heard you speak.
There is some data on that group as well. There are some data out from that transgender group showing that there is increased athero at least.
So probably for him, I think I'm fairly confident he's on a statin, but I think for him, a CTA might be a good thing too, and maybe repeat it after a couple of years and see which direction he's going. So
I mean, I have to say, if their CTAs are clean, at least to my eye, I give them a 5-year pass and tell them that they're good for at least 4 to 5 years unless something changes. But yeah, if you see a lot of plaque, I think it's worthwhile to think about that. At least to get a baseline scan, I think is helpful. Establishes risk.
Behind you, Dr. Gordon.
Thank you so much. That was an excellent presentation. One question I have is in intermediate risk patients, just like an example that you showed, or you were a wonderful responder to like soft plaque got better with statin, and you showed very nice scans. How do you balance the risk of radiation with a repeat scan versus maybe getting other physiologic or getting angiogram? How do you, day-to-day practice, how do you balance those?
Yeah, no, great question. So, you know, fortunately, the biggest advance in CT is not, I don't think, is AI or these new scanners. I think it's the dose reduction. We went from 15, 20 millisieverts, what a normal technetium scan may give you, to now 1 to 2 millisieverts, which is background radiation. It's not zero, but it's very reasonable doses, and you can get sub-millisievert. You can get down to the same dose as a mammogram, and I've never heard a woman say, I'm not going to get a mammogram because I'm worried about the radiation exposure. So I think you can, if you can get down to mammogram type doses under 1 millisievert, I don't think the radiation risk should deter you. I'm not a big believer in very low doses really changing the scale much. it's probably the large doses when you get over 20 or 25 millisieverts all at once that you probably have an increased risk of cancer. That's when you start getting double-strand DNA fractures, and they can go on and propagate and start causing bad things to happen. Our body can repair low-dose radiation. That's why the astronauts, they get a lot of radiation in space. I worked with Dr. Kara with NASA to try to model the radiation exposure. It's a big problem because they can't put lead on the spaceships because it's too heavy. But when they're outside of our atmosphere, they get a lot of cosmic rays. They get a lot of radiation. So that's like their biggest concern in going to Mars, is that they're just going to fry to a crisp on the way there or on the way back. And so the body can repair low-dose radiation damages as we go. Pilots get a fair amount of radiation. They have big windows in the front so they can see where they're going. They get a fair amount of radiation, and there's never been an increased risk of cancer for pilots. Trust me, American Airlines and United would have been sued a long time ago, and Delta would have been sued a long time ago if there was any signal from the union that there was a cancer risk for pilots.
Do you, as a sort of a corollary to that, do you see any future in detecting coronary calcium with a plain old chest X-ray?
Yeah, I mean, there's definitely research being done. There's actually a researcher here at University of Minnesota who's doing some really nice research, enhancing the images from X-rays to look for coronary calcium, and maybe with AI. Right now, it's not great because the contrast resolution, the ability to see small calcific plaques, is not really there probably with the standard X-rays or even fluoro. But the coronary calcium story started with fluoroscopy. It was actually early observations on fluoro from the cath lab that spurred on people to think that detecting calcium may be a simple way of identifying those patients who are walking around with advanced atherosclerosis. And that's where the whole concept of CT for coronary calcium came from. So I do think that will get better, and with the AI tools and maybe better resolution of those images, we might be able to get away with much easier and more widely available, cheaper tools that we can have in our offices rather than these fancy scanners that take up a lot of space and cost a lot of money to get running.
So for those people who have a calcium score between like 1 and 100, and would it be ideal to then further test their plaque quality to see if they stay the same or they progress or start treatment?
Yeah, I mean, I think if you have a low score, especially if you're in the low risk, if your percentile risk is low. So a score of 5 in a young woman is terrible because they have athero, and plaque begets plaque, and they're going to just go up from there, and they're on a bad curve. They don't need an aspirin because aspirin is short-term benefit, and their score of 5 isn't going to cause them any short-term events. I wouldn't put them on an aspirin, but I think if they're above the 75th percentile, and many preventive doctors would say if you see any athero, just get them on treatment, right? Because they have plaque now. You've documented it, and it's it's dealer's choice in the guidelines. But I like to try to convince them that they have a little athero. Let's put you on at least a low-dose statin, and then I just follow them, and I get another scan in 3 years. You could do a CT angio, but I think 90, unless they're symptomatic, 95, 98% of the time, you're just going to see a little bit of plaque, and that correlates with the calcium score. And I don't think there's a huge benefit to doing a CTA every time you see a calcium score of 1 or higher.
Phenomenal talk, and thanks for enlightening us with the data. I have a couple questions. One is practical. Beyond which calcium score does the AI plaque does not add benefit? So if you have somebody with a calcium score of 1,000, does that make any sense? I mean, the patient is already super high risk.
Yeah.
Are you going to do that? The second is, I love your comment about those that CAD-RAD0, you see no plaque, but the eye sees plaque. The risk is very minimal. I'm reflecting that about the PCAT, that's the pericoronary attenuation fat data, that looks too good to be true, that they can sometimes predict risk even when you don't see any plaque.
Great point. So first, the pericoronary fat, or the inflammation around the coronary, I agree with you. I think we have, in 10 years time, there's 2 publications so far, and they're both retrospective cohorts. So that's just very strange for a company to not publish anything. They actually they're in the UK, the company, they went to the NICE guidelines, their NIH kind of guidelines, and NICE said, they laughed at them. They said, there's no data here. You can't show us a retrospective cohort. You didn't do any prospective studies, and I don't know why, but Scott Hart is a prospective CT study with outcomes. They're literally miles away from this company, and they have not reported on those results. Either they didn't do them, or they didn't like the results. Promise has CTA with follow-up. Ischemia has CTA with follow-up. Got nothing from any of those. So I'm a little skeptical that the data is not that great and that they're cherry picking, but they keep claiming that the great data is still to come. So the concept is if they have inflammation around the coronary, that they're going to have more events, that it's going to cause atherosclerosis, or the atherosclerosis is causing inflammation, and that's active atherosclerosis. I'm not so sure yet, and I've tried to make similar measures with other tools, and even in these longitudinal trials, and it's just noise. CRP went down in my the Reduce It trial or the Evaporate trial with icosapent ethyl by 40%. So we should see improvement in the fat attenuation index. And we saw no changes whatsoever. It just didn't move. So maybe we measured it wrong, but I'm not a believer yet. We'll see. I think it's too good to be true, but we'll find out. The other question I forgot now.
Is it beyond what calcium threshold that does not add?
Oh, yeah. So I think it's above 300. You're already very high risk, and I would treat them as secondary prevention. And I don't think we need to re-stratify anybody who's secondary prevention. I think if you've had an MI, we know we got to be on top of that. Obviously, if they have subsequent problems, then we get even more serious. But I think over 300, you're going to start losing incremental benefit.
Are you ever able to get your asymptomatic CTAs covered by insurance?
There are some patients who you can get covered. Certainly, if they have atypical symptoms to go along with their asymptomatic nature, right? Right? Have you ever got short of breath when you're running for 10 miles? Oh, just got exertion. So you can probably come up with something sometimes, but truly asymptomatic people right now, it's probably pretty hard. There are a few small insurance companies that are pretty robust in their coverage, and they offer it just to try to be unique for these high-end patients. But I think we have like the longshoremen near us, and they work at the docks, and they have incredible insurance, so they get it paid for. But I don't think that's the norm right now.
Dr. Budoff, thank you very much for your time and expertise this morning. We just have a couple virtual questions from our webinar, the first of which comes in anonymously, but the question is, has there been a significant uptake of CCTA in LA as a first test, or is it limited to a few large centers?
Yeah, so has there been a significant increase in LA? And I think all the centers that I'm familiar with that have been doing CTA for any period of time now are getting an overwhelming number of referrals. If you try to call UCLA today, main campus UCLA, say I need a CTA, they'll tell you that there's a 3-month wait. If you call Cedars-Sinai, one of the Dan Berman and one of the pioneers, they'll tell you there's a 6-month wait. We're a little bit better at my center because we put in a second scanner, so we have literally just 2 scanners that only do cardiac CTs every day. But there is quite a wait at many institutions, including those that are just getting the equipment. So I think it's going to become a problem. In 2016, the United Kingdom, the NICE guidelines, their National Institute of Clinical Excellence, said CT should be first for all chest pain. That's it. There's no other test you should order but a CT angio for atypical, typical, for mild, for all, no matter what the chest pain, CTA, first line test. And to this day, they don't have enough providers and enough scanners to handle the volume. So there's still a lot of treadmill, the nuclear and treadmill and MR data continue to decline in the United Kingdom year over year, but they still can't handle the capacity. So I think as we continue to get more and more data and people want to do it, the capacity issues are still going to be there. I don't know, do you guys have a big wait or is it not bad?
Yeah, 2.5 weeks.
Yeah, that's great. Yeah, that's about where I am now. But I think it's going to keep getting worse. No, I mean, it's just we've seen that as people, because as doctors start to use it, they understand the value. They start seeing the plaque. Okay, they didn't have a stenosis. That's great. They don't need a stent. But we have this great data now to show that all that plaque in there, it's going to cause problems downstream, and we can get it treated. So I think it's not just a yes, no for stent, no stent. The athero story is, I think, more robust than that.
Thank you. So there's just a couple more here in the Q&A pod. The next one is for those of us who don't have access to plaque quantifying software, how should we report on plaque progression?
Yeah, so if you don't have plaque software, it's a little bit hard. I mean, I used to do it just visually, that there's more plaque. You can look at segments of involvement. It's not hard. If the mid-LAD didn't have plaque before, and now there's a new, plaque in the mid-LAD, whether it's mild or moderate or severe, then that's progression. So you could just look at what we call segment involvement score. It's pretty simple, but it actually predicts risk pretty well. So just the number of coronary segments that are involved, and if they're getting worse, if there's new segment involvement, things are getting bad. And I still use the calcium score as part of the CTA. And if the calcium score is going up a lot, again, that's not a statin effect. That's new plaque being laid down. There's no way that statins cause a 30% year-over-year rise in calcified plaque.
Thank you very much for that. So there's this last question in here. It's a two-parter, so maybe I'll start with the first part. And this is from Dr. Ali, who says, thank you for the excellent talk. I have two quick questions. First, how should we interpret coronary calcium scores in patients who are already on statin therapy and do other non-statin lipid-lowering therapies similarly increase calcium scores?
Yeah, so again, they definitely do. There's a small increase in calcification from statins, and we saw that with Repatha as well, with evolocumab in Dan Berman's study, an increase in coronary calcification. We didn't see that with icosapent ethyl, but maybe that's just the study we did. But again, it's going to be a small increase. So you're not looking for 5-10% changes. That might even be noise of rescanning. If you scan somebody later that day, it might go up by 5 or down by 5%. But if that guy with the testosterone, his score tripled. It went from 100 to 400. That is not on treatment statin effect. And he was on statins and he was on PCSK9. His LDL was low. That is not a statin effect. That is something else going on completely. And I think you can tease that out.
Excellent, thank you. We did have one more just come through, plus the second part of the previous one. I'm going to ask the one that just came in because it has to do with testosterone, so I think it's a good segue. This comes from Rory, who says, I heard your comments about following patients on testosterone with coronary calcium score. Do you start with the CCTA first to see whether vulnerable to plaque, to see whether to advise against testosterone? Also, same question regarding keto diet.
Yeah, so I still think that for asymptomatic people, it's much easier and much less expensive. I think you guys still charge $99. I think a calcium score is still the easy entryway. And if it's 0, honestly, in an asymptomatic person, their risk is super low. The incremental value of statins, I think, is not there for the next 5 years. It's not a lifetime warranty. It's just like a negative HIV test. It doesn't mean you can't get HIV. It just means you don't have it now. And so I'm not saying that forever and ever they'll never have an event, but I think a calcium score is enough in most asymptomatic people.
Great, thank you. Okay, so the last question again comes from Dr. Ali. And he says, what are your thoughts on using annual low-dose chest CT for lung cancer screening and calcium assessment score and monitoring?
Yeah, no, I think the calcium score from a low-dose lung CT is almost as accurate as a gated calcium score study, and it can be quantified. The radiologists don't often quantify it, but you could actually get an Agatston score, a calcium score from that. But at least they often will, at least hopefully semi-quantify it, say that there's mild, moderate, or severe athero or calcification on the scan, and that is predictive. In the low-dose lung CT literature, a high, what they call an ordinal score, kind of a semi-quantitative score, a high score will increase the cardiac death 4-fold. So I think it does work almost as well as a gated calcium score, and I think you can use it. It'd be hard to use it serially. Unless they did do some type of quantification, but you could actually ask them to do an Agatston score, calcium score. It's a little bit, it's not gated, so there might be a little bit of motion, but it's not a bad correlation.
Excellent. Well, thank you, everyone. Thanks for coming. Have a great week, and thanks to Dr. Graham for showing up. Good to see you. Thanks, everyone.